Honorable Director, Dean, Faculty in Charge Research, respected faculty members, and our dear colleagues, a very good morning to one and all. Research is to see what everybody else has seen and to think what nobody else has thought. With this thought in mind, I, Shikha Sahu,
and I, Manali Jain, welcome you all to the second research day of Sanjay Gandhi Postgraduate Institute of Medical Sciences. It is on great occasion like this, we get opportunities to explore our knowledge and understanding. We look forward to get an exposure about what the best of the brains think about this very dynamic issues of research. I would request Honorable Professor R.K. Dhiman, Director SGPGI, to come to the dais, and I would request Dr. C.P. Chaturvedi to kindly escort him. I would now request Professor Anish Srivastav, Dean SGPGI, to come to the dais, and I would request Anshika to kindly escort him. I would now request Professor U.C. Ghoshal, Faculty in Charge Research, SGPGI, to come to the dais, and I would request Sushmita to kindly escort him.
before the launch of our research day, I request all the dignitaries on the dais to kindly light the lamp and inaugurate the function. I request everyone to stand up for the Saraswati Vandana. I now request Professor Ghoshal, Faculty in Charge Research, to kindly address the audience.
Our respected Director, Professor R.K. Dhiman, Dean, Professor Anish Srivastav, the faculty members from outside the institute who have come all the way to judge work of our students and faculty members, and all the faculty member and students who have gathered here physically and those who have gathered online. It is really a pleasure to be in the forefront to organize this second research day, because we all know that SGPGI has three pillars. The first pillar is patient care. The second pillar is teaching and education and training. And third pillar is research. Though the third pillar is research, actually it is not really third, because we all know without good research, one can't do good patient care and can't serve the nation, because we have to really bring research to the local need so that we can bring out better diagnostic facilities, better treatment facilities in a cost-effective manner. So I really welcome you here. I also really congratulate the 13 faculty members who have become included in the 2% world scientists this year based on the survey of Stanford University. Let me name them. Professor Rakesh Agarwal from Department of Gastroenterology, who is currently in Jipmar, Pondicherry as director. Myself from the Department of Gastroenterology. Professor R.K. Dhiman, who is an alumni of this institute. He is the first alumnus of this institute, and currently he is our beloved director. Professor U.K. Misra, Jayanti Khalita from Neurology. Professor Narayan Prasad from Nephrology, Professor R.K. Gupta from Radiology, Professor V.K. Kapoor from Surgical Gastroenterology, Professor Rohit Anthony Sinha from Endocrinology, Professor Ujjwal Poddar from Pediatric Gastroenterology, Dr. Alok Kumar from Molecular Medicine, Professor Sarita Agarwal from Genetics, and Professor Gaurav Agarwal from Endocrine Surgery. I really congratulate them. I really felicitate them from these dais. And let me tell you, we want more and more in the coming year to be included in the list so that our institute, our country become proud of them. Thank you so much. I'll now request the director to actually proceed with the further proceeding of the conference. Thank you.
Thank you so much, sir, for your precious words. I now request Dean Professor Anish Srivastav to kindly say a few words.
Good morning, everyone. Professor Dhiman, the director, Professor Ghoshal, the FIR, the faculty members of the institute, and from outside, the various judges for the various poster competition who have spared their valuable time to make this second research day a great event. So for this, I congratulate Dr. Ghoshal and his team. They have done such a hard work, and now we are seeing the results or the fruits. As a dean, probably I should say a couple of points to the researchers, the students, and the young faculty members regarding the research. So the first point is that whenever there is a research question in your mind, please go through the extensive literature which is available at the click of the mouse. So And so that you can actually know what are the gaps in the knowledge, what all exists, because the idea which has come to your mind might be already existing. A lot of work might have been done. And that's what the students, when they go to their guide, it's the job, the first thing, initial thing which the guide as well as the student must make sure, and then try to fill in the gap, whatever is there in the existing literature and what they want to do. And of course, one has to look at the resources. That means the areas where they can really work. It should not be something hypothetical that if that particular area, clinical work or research is not being done in the institute, then or that those facilities are not available, there is no point harping on that. And the second thing is for the again for the postgraduates, do not hesitate to write even a case report. See, writing even a case report, which everybody might think that is that really research? Yes, it gives you the fundamentals. The bricks are laid there and then only. I have over my 35 years of career seen even at the level of associate professor, they are not able to write the things because they have been brought up in whichever institution or taught that way. And they were thinking these are the small things, why should I write? And the bigger areas, they take it as a first writing platform, and then they are not able to express. I am telling you, even writing one good sentence which carries or which is the gist of the matter, it takes days together and sometimes weeks. I have myself revised my manuscripts, written by myself 10 times. So that kind of work, hard work, we all should be willing to do. And the third point is the plagiarism. That's very important point, because one of my own PGs was debarred for 3 years by a journal. And he was bringing the manuscripts to me again and again. And I was every time asking him that, in the discussion, I'm telling you the areas where you people tend to do that, take the discussion from somewhere and cut and paste. That practice should be absolutely forgotten, and it will give you a lot of points in favor. Yes, they also allow 15 to 20%. We all know the name of the institution, SGPGI. When it goes to the publication, even SGPGI, the name of faculty members, because they are repeated, might be taken as plagiarism. But that part is acceptable. What is not acceptable is cutting and pasting the main important things. So I think there are a lot more things, but with this, I think I thank you all. It's a great occasion. Let's enjoy it. Thank you.
Thank you, sir, for your enlightening words. I now request Honorable Director to kindly grace us with his words.
Thank you. Dr. Anish Srivastava, the Dean, Uday Ghoshal, Professor in Gastroenterology, and Faculty in Charge for Research. Dr. Gaurav is here, and Dr. Chaturvedi from King George's Medical University. My colleagues, students, ladies and gentlemen. I would say that I am overwhelmed seeing the response from the faculty and more so from the students. As far as this research day, that is the second research day of the institute, the people, they are participating with all enthusiasm that is required also. And I cannot overemphasize the importance of the research that has already been talked about by Professor Anish Srivastava. It is important of the institute like Sanjay Gandhi PGI. And today what I have observed that almost all departments, there is or there are good research that is coming from all departments. And there are the group projects also. And more importantly, when I saw the students, they are really involved in kind of this research also. This is very important if you see for the students as a part of their training also. It is not only the patient care, not only the teaching, but also the research. When I was here, we used to write the 2 projects. And before we get the degree, and both the project either accepted or published. I think these norms are still continuing, but they are somehow diluted. I think that is I would say, some negative point. We should have at least 2 research projects for the DM, MCH, and they should be either accepted or published also. I think we have to give the thirst in this area of the research also. I am also aware that for the research purpose, there are several workshops are being organized, particularly from our faculty, Professor Amita Agrawal. And initially it was, I think, Dr. Rakesh Agrawal and many more. I don't remember the names. I think that is a good practice that should be done at least 6 monthly to all students as well as the PhD students also, including the DMN and MCH also. On the day of the research, I have seen the quality of the posters also. I have seen almost all posters. I have not gone through the details, but at least I have read their title. And I have seen the publications also. They are published in good journals of the repute internationally also. And there's a good impact factor also. But we have to go even further from this point, that we must be able to produce even better results, better research, and the better publications also. What I have observed, the studies, those have been presented by the student, they are yet to be published. So I wish that the conversion into the publication should be very high. So I request all the faculty as well as the head of the departments that promote as far as publishing these studies are, because the most of the work is already done, that the data has been collected and has been presented as an abstract. So you know what is the study. So all these studies which have been presented today, they should be published also. That is something I would like to say. And so that next time the published work, we have the separate category of the published work, which is being presented by the faculty, so that they can go the next time once they are published. Because at the moment the research might not have been completed, maybe on the way of the completion also, but once it is completed and published, it can be presented again in the next one research day also. I think last thing that I want to say, and that is my responsibility also, that I'm asking you to, for the promotion of the research, you do research, but there must be some lacuna. There must be some issues that you might not be having this instrument, that instruments, or the facilities in other forms also, or even the reagents also. So I've been working on that field also. And Professor Amita Agrawal particularly is very keen that all the reagents, they should be procured in minimum possible time also. And she is working, I hope things should be, I think, in a way that all the students or the researchers, they should be getting the reagents on time also. And there might be other issues also, might be the instruments and other things. So I request each and every head of the department or the faculty who concerned, who are basically guiding their students also, if they need anything, I think this is the right time that you should forward the need or requirement of the department or the particular research project to the director's office and would like to procure or made available for the use in your department also. I think lastly that I'm really very happy today seeing all these kind of the research. I have seen the research days in the PGI Chandigarh also, where I have come. I think it is not less than the PGI Chandigarh. That is something I have come to know today. And I'm proud to say so also, that we are not behind the PGI Chandigarh and we can cross that institute as far as the research is concerned. With these things, with all kind of the enthusiasm that we have today, ये बरकरार रहना चाहिए आगे भी और इसमें कई गुना वृद्धि भी होनी चाहिए. With these words, thank you so much, and I must congratulate Dr. Ghoshal and Dr. C.P. Chaturvedi for their hard work for getting this research day in a very successful manner. Thank you so much once again to everyone. Thanks a lot.
Thank you so much, sir, for your aspiring words. We now start off with our keynote lecture session, and it gives me immense pleasure to introduce Dr. Ananya Das, Professor of Medicine at Creighton University, USA, as our first keynote speaker. He was in the third batch of DMs at Gastroenterology Department, SGPGI. He then went to United States to attain his board certification in internal medicine. Further, he was appointed as professor and chief of endoscopy at Mayo Clinics in Scottsdale in 2004. And in 2015, he established his own digestive health center. And the topic for his keynote lecture is Sustaining Research Quality and Tempo. He would be joining us online.
Good morning to you all. My name is Ananya Das, and I am an alumnus of SGPGI. I'm sorry that I have to do this through the recorded option and could not do it live, primarily because of the time differences. Anyway, Uday asked me to talk to you about research. The first question in India is really, how is research going on? And that really looks a little bit of circumspection. Just to clarify, when I mention about research, I strictly mean biomedical research, and which is likely a little skewed towards clinical research. Publications are kind of currency of research, and number of publications originating from India are surprisingly low. This is a chart of a country-wise publications in core biomedical journals from 1995 to 2015, the last 2 decades. And if you look at it, the number of annual publication, US is the highest. China is quickly catching up like everything else. And surprisingly, India does not even show up in the top 10, and actually not even in the top 30 in number of publications. How about quality then? And that's a little bit subjective. And if you take, for example, randomized controlled trials, which are generally considered a marker of good quality in terms of science and effort. This is all randomized controlled trials published from different countries in 2019. Again, US is high, about 5,000 publications. China is pretty good, more than 2,000. I put Brazil as a comparator. because it's one of the BRIC countries and similar to India in many respects. They're at about 1,000 per year in 2019. However, India is a mere less than 100, 70 in 2019, before the pandemic. If we critically look at the discrepancy, we may find some answers. This chart takes India as the base parameter. This is the number of our cities just that we just discussed. Let's go to healthcare spending as a percentage of GDP, which is definitely very low in India compared to all other countries we are considering. Remember that these are not absolute numbers, but relative proportion with India as the base parameter. When you go to research spending, same thing, India spends the least. How about medical schools per million of population, which is actually pretty good, better than US. China, of course, has more medical schools. But the same story when you go to number of researchers, and researchers are doctors, physicians, MDs, scientists involved in biomedical research. Number of researchers per million in India is only less than 200. A lot more in the US, even in China and Brazil, they're much higher than India. One would think that the salary for the researcher in India must be low so that nobody is attracted. But to the contrary, researchers in India are quite well paid compared to Brazil and China. Definitely less than US, but here is India. So it's not really salary. I know you will be interested in the salary data. This is actually data from the 2016 Davos World Economic Forum, compiled in 2016 and published in 2018. This looks at the physician, PhD professors in an academic university, how they're paid in the rest of the world. The left chart shows the average salary of researchers in different countries. India is actually just after US. It's paid 5 times the world average salary for lay public. China and Brazil is less than India. US is very high, almost like 17 times than the average salary, and I'm not complaining. If we go to the right chart, then you see that the salary, average annual salary of researchers in India is actually the highest compared to, of course, the average cost of living adjusted salary of the population. And this could be because the average salary in India is generally low, about $500 annually. But it's interesting, in India, physicians and researchers are very well paid. So I think I'll leave this topic here. But it's important for all of us to ask that what really is the issue? Is inaptitude is the issue? I don't absolutely think so. In my old institution, Mayo Clinic, there are about 1,000 physicians, scientists, give and take, a few, and about 1.2% are Indian first-generation immigrants. They're just like us. They went to Indian schools, Indian medical schools, universities, trained in the Indian system, and then immigrated to the US. Look at their productivity. In Mayo Clinic, about 10,000 research publications were published in 2020. 2,300 of them had authors who are of Indian origin, primarily first generation Indians. So basically 1.2% outputting 23% of the academic output, which is really excellent. So obviously we really need to look in more detail what exactly is going on. But let's move to the next topic. What can we do about it? How can we improve research productivity, stimulate more research and sustain it, quality research? Let's start with the junior faculty, senior trainee. My first advice to them will be to first orient yourself in life. Look where you are and where you want to go in, say, next 5 years. Think about yourself, career, family, academic interest. The second thing that you should do that you keep educating yourselves. Do not stop learning just because you completed a fellowship or a residency. And in the same time, try to diversify your research interests. It is always something more about the journey than the destination. I'll give you a personal example. I completed my MD from Chandigarh in 1990. During that time, I had some exposure to clinical research. I wrote my MD thesis, which was required for graduation. And from 1991 to 1993, I was in SGPGI. Started with the Biostatistics course 101, which all of you did, I guess. I did a couple of DM projects, and that's where the research orientation education for me really started. 1994 to 1998 was kind of a difficult period for me. I immigrated to the US, learning the system, was going through that retraining again, which I did not really cherish that much. But I quickly realized that to maintain research and keep publishing, I really need to go into the fringe areas. So I started learning about decision analysis, economic analysis, meta-analysis, and learned them and kept on publishing. In 1998, I became a faculty, and till about 2010, that was a golden period. I did a lot of core subject research. As many of you may know, my subject interest is in advanced endoscopy and endoscopy related matters. And at that point, the snowball really starts to happen. Your colleagues, your mentees starts to publish, and number of publications go up, and volume do not remain an issue anymore. Happens to every faculty who moves up. In 2010, I had to change my perspective from academics to more into administration and clinical care. But I continued to do some clinical research. I realized that quality improvement projects, system analysis, looking at how the system in endoscopy works is actually a very good area of research and really quickly publishable. In 2015, I took a bold step. I got interested in real data mining, started doing predictive analysis. In 2018, really went into AI, learned how to code, learned machine learning, image processing. As you know, that endoscopy is a lot of images, and I've been working on many projects related to image processing, analysis, and diagnostics. In 2020, sitting at home because of the COVID, I started learning about GIS, Geographical Information System, maps, and quite a few projects. These are really very good projects, and some of them are started to get published. So that was my journey, going back to diversification in research area, new learning. My recommendation to the junior faculty and trainees will be to go back to biostatistics, go back to the level 2, learn more details about regression analysis, survival analysis, know how to work with different statistical software. If you're interested, go to decision analysis, meta-analysis, different system analytic projects. Data mining, predictive analysis is a gold mine of information. I'm sure over the last 3 decades, the Institute has lots of data and databases, use AI, machine learning, maybe consider learning how to code. I know for the younger people, coding is going to be as important as internet is in our lives today. And for the older generation, it actually keeps Alzheimer away. Very preventive against dementia has been shown in theoretical research. Image processing, doing geographical information system research. The blue font are the software names. They're actually a very good software. They are easy to learn, as easy or as difficult to learn as like PowerPoint. Takes about a week or so to learn and get good grip on the software. And the best part of it is that all of them are actually free for academic user. Download, learn how to work around, start a project. It should be that simple. What about the senior faculty? And again, that's in a nutshell: leadership, mentoring, vision, and fairness. That's probably the most important part of it. You do not want to steal the limelight from your mentees and students. Share it with them. In the US, for example, every division or department chief goes through formal training of research development, strategic, proactive, catalytic, and capacity building exercises, very meaningful and powerful words. If you are interested, you can actually look up the National Organization of Research Development. There's a lot of learning material on this. Next, what the institution can do, and of course a lot, probably the most. Research grants, starting from seed grants, small grants at the departmental level, career development grants, going up the ladder. One thing is very useful, the benefactor grant. Get money, ask money from the community, alumni to donate to the benefactor grant controlled by the institution. In US, it's actually very, very nice and very robust way of getting research grants. Research facilities and infrastructure is very important. Have a good IP rights policy in place. And that's important to make your faculty interested in commercialization of research. For example, in Mayo, 50% of the profits from a money-making research projects go to the investigator, 20% to the department, and 30% rolls back to the institution. Another thing, public communication, public visibility is very important. Make sure that everyone knows how excellent your faculty is in research. Be active in social media. Publicity is key. Academic incentives, and that's a little bit controversial. I know that you guys know about academic metrics, impact factor, H index. They have their role in deciding promotions and career development, but then some they're misused a little bit. There have been so many fake journals coming up to bring up the H index. One of the things that have been happening over the last decade in US in academic medical centers is academic relative value units, which basically means that a peer-reviewed point system is developed, and simply speaking, at the end of the year, you get a substantial cash bonus for your academic achievements. In many famous institutions and medical universities, almost 20 to 25% of faculty salary often comes from this academic cash incentives. The engine of capitalism works for research as well. Let's summarize. We talked about funds, very important. Needs to be a lot more of funds to do good research. Infrastructure, equally important. Innovative research curriculum. Again, we need to build research manpower. This probably should start from medical school or even from high school level. Doing real life research projects should be given top priority. This is very common in the US, particularly where research is thriving. think about it. If I were to decide about a medical school admission, I would hands down take a high school student who goes around the community hospital and tabulates the commonest cause of mortality to probably someone who scored 99 percentile in the NEET exam because he or she could calculate the elastic energy of a particle collision or can memorize atomic weight of selenium, for example. Research has to be contextual. Need-based research is very important. Nobody's expecting or eagerly waiting to get a Nobel Prize winning basic science come out suddenly from an institution, but homegrown original research is very important. And I remember one of my mentor, Dr. Nayak, always saying that do not mimic the West. Epidemiology, public health, clinical outcomes, these are low-hanging fruits. You can really do it fairly easily without much fund. It just needs time and effort. Research should be translational, collaborative as much as possible. Market-oriented research is important for sustainability. Priority should be given to innovation. And last but not the least, research ethics and integrity is very important. Cannot go anywhere without that. Research is very important. It has tremendous downstream benefit for the researcher, the group, the department, the institution, and the community as a whole. So do not please give up on research. Think how you can do more of it. Thank you.
Thank you, sir, for valuable suggestions. It is my pleasure to invite Dr. Sudipta Mukhopadhyay, Professor, Department of Electrical and Electronic Engineering, IIT Kharagpur. IIT Kharagpur is the only IIT institute which has started the School of Medical Science and Technology. We are obliged that SGPGI has been actively collaborating with IIT Kharagpur. He'll be joining us online and will be speaking on India needs hybrid research, health, and engineering.
Good morning to you all.
Morning.
Yes, Professor Sudipta, you can start. Share your slide and start.
So please unmute from your end. Yes, sir.
Good morning to you all. I am Sudipta Mukhopadhyay from IIT Kharagpur, from the Department of Electronics. First, I would like to thank the Director of SGPGI and the Organizing Committee of Second Research Day of SGPGI for inviting me and giving the occasion. Today, we'll talk about India needs hybrid research, health and engineering. For that, first let us look at the evolution of medicine with time. 1500 to 1300 BC, that in Egypt we get that healthcare was there, and in India, 800 to 700 BC, that the medicine actually reached a high stage of sophistication, and we get that the surgery was performed, which were 100 years back or so, that they were taking very advanced. That we get the name of Shushruta for his book written as Shushruta Samhita, and we get a lot of stories about him. One of them that about his dissertation. In his dissertation, he was given the problem statement by his supervisor that he has to find out a herb or plant in that small forest where their school was located, which doesn't have any medicinal value. And Shushruta, though he was a very good student, he failed again and again and asked for extension. And at the end, when he submitted his thesis, he came to the conclusion that all the herbs and plants, they are useful. And that he came to the conclusion through the use of them, that by the animals, by the people in that way. So we get that initial part of the research in any field, including medicine, that was based on the actually observation power. And if we look at how was the research, or that the value of the research, and how the treatment was going on for the people, how they are reaching there, the mass. We get at the time of Buddha that the kings and chieftains, they could have access to the treatment. The merchants, they could have access, but the common mass has very little access. That only that some privilege was given to the monks, the Buddhist monks who are in Sangha. So that was the situation. That means the coverage was not full. And if we come forward and go, that in 1796, a vaccine was developed by Edward Jenner through the scientific study, though the concepts were known in India and China, and with the help of the Ottoman Empire, it has spread in North Africa and in Europe. But Jenner did a good study, which is repeatable, and that's why he is known as that father figure of vaccine. And after that, we get that the invention of X-ray, which is again some accident, and penicillin, again a great discovery that also came through some accident. So we get that the attention and that power of observation of the researchers were the key in this. But after that, there is a change that for the ultrasound, that an engineer, Tom Brown, and a physician, Dr. Ian Donner, they came up with that equipment called ultrasound and the new modality, and they patented it. So it doesn't look like that it is just an accident. So they deliberately worked on that and came with very useful new modality. And afterward, that computer tomography, PET, MRI, all of them, the new equipments have come, which has become that ear and the eyes of the doctors, which are developed by the engineers, physicists, and mathematicians, not limited. So the scope of the research was not getting limited by the physicians only. Now let us look at that where we stand, that who mandates that the physicians per 1,000 people should be one. And India, we are the third biggest economy at this moment in terms of the GDP, when you look at PPP way. However, we are yet to get that number, and 2024, we expect to reach that number. But if we look at that who are our competitors, we get that they have more, and we get that is the minimum, actually, the point that we should reach, and we need to move ahead because we need more experts. Even in US, they cry that they do not have more experts. What we would look at that, what are the things we can expect from the healthcare, that more experts, more productivity, more coverage, better accuracy, and more economy also we need to serve more than 1 billion people. And all these things can be helped through the engineering. Now here we take an example of that content-based imagery travel research we do, that we know in Google that you can give an image and you can get similar images In case of Google, they look at the keyword associated with that image and fetch other images which have the same or similar keywords. However, that here the things are a little different. That's why we call content-based image retrieval, where we look at the internal features of the image and try to find out similar image. Now, in that way, we have the benefit that we can get truly similar image. Think of that you have a medical image and you are pointing out some region where you think that some pathological bearing region is there. You take that as region of interest and give a query. And in the database already a lot of images are fed, that similar kind of images. So you fetch them and you can look at them. And the context is here in the radiology, where the images nowadays are kept as in picture archival and communication system, and the decisions are kept, or the readings of radiologists are kept in a radiological information system or RIS. So if you can actually pull out that similar images and their ratings, that readings, then the young radiologist, they can quickly get an idea that what was the actually the diagnosis, and that whether something really is there or not. So that it can help them as a self-learning tool. Today they are learning only when the seniors can give them the time. Now in other time also they can actually learn from the experience and the labor of their seniors, however without bothering them. So that's the benefit of the self-learning tool. That same thing can happen for any practitioner. They may have a doubt while doing the reading of the images. So that similar images, as they can come with their ratings or the diagnosis, then they can use it for differential diagnosis. So while actually a practitioner, it can help in that way. And the third way it can help, that as a regular CAD, which can be a second read, because as we get similar images, we can, and the decisions what they are made, we can collate them and we can come to a decision, and we can give also a score that how sure we are about the decision. So not only that, it can act as a full-fledged CAD, and it can help the radiologist to improve the accuracy. And we know that radiologist with a second read as CAD, that the performance is much better. That is already established. And there is one more benefit, as it is a bottom-up approach. That means using the local data, it is coming to the decision. It is less biased by the racial variation. Here we should keep in mind that all the CADs, most of them, they are developed in that Europe or America, and they are trained on the Caucasian data. So when they come to India, that the false positive is very high. In PGI Chandigarh, when I interacted with the radiologist, I find that penetration of CAD is very low because of the price. And even if it is available, that the radiologists are skeptic about them because they give high false positive. So that issue we can address here, because it is grown on the local data, and it can be taken to any place, and we just change the database with the local reading, and we can actually get rid of the bias. So that's another benefit of this kind of CAD. And as it is our that homegrown kind of thing, that made in India, so it can also help us to tune the parameters. The CAD as a second read is one use, but there could be more use. We know that we do not have any screening program. One part of it is the funding in healthcare, but other part, even if the funding is there, you cannot get the number of radiologists to read that data. It is not simply possible to do that manually. So what we can do, we can change the operating point of the CAD, and we can ensure that 100% specificity, and thereby eliminate those actually data which are we know they are normal. And we did a small study with mammograms, and for the microcalcification, we could actually achieve that thing, that it is possible to get 100% specificity, and we can reduce that number and thereby reduce the load to the radiologist, that they need not have to go through all the data. And this thing we have tested for the lung nodules and ILD patterns of the HRCT with the help of PGI Chandigarh, and that are validated with AIMS Delhi. So you can try it on any other modality, any different modality, and you can take it the benefit of it. And here before ending, I would like to tell that if you have to do research in medicine, one need to be abreast about the medical technology as well as the engineering part of it. And as it is very difficult to get a perfect combination, what we can do, we can have our a group where we can actually help each other. We can make a group which can share and actually counterbalance our points, and as a group we can achieve that goal. Thank you. If you have any query, feel free to ask.
If there are any question, Professor Sudipta is available to answer. No question. Professor Sudipta, can I ask you a question? That in your institute, I know things are very less bureaucratic than many other medical institutes, but what are the usual difficulties which one faces during innovation and taking it up to the application level in Indian scenario?
In Indian scenario, when you do the medical research, IIT Kharagpur is coming up with a medical school first, but till then, till that comes up to that glory, that we have to depend on actually other medical school. That is the first point, that we need to form a team. And unless the people are like-minded, I find that just having an MOU with other institute doesn't help. That is the point number one. Point number two, that taking it to the next level becomes a problem. I have done 2 projects from DIT, and every time they told that you have done a project, why don't you shift? That means you do something else. See, this is done. But you know that the simple theory that if you want water from a riverbed, you need to go deep. And that 2-year, 3-year research is not enough to actually come with something that which can be translated to practice. And that part we still lack, and we are learning that part. Presently, with the help of Abdul Kalam, the Technology Innovation Fellowship, for some of my other work, we are trying to do the technology transition. So we are just learning that part. But we need more collaboration with the medical school, and that technology transition still is a challenge.
No other questions? Thank you, sir, for an illuminating talk. We have also introduced an oration of SR Nayak Award in Research. And next up, we have SR Nayak awardee, Professor Gaurav Agarwal from Department of Endocrine Surgery. And he will be speaking on Less is More, Evolution of Frugal Sentinel Lymph Node Biopsy for Breast Cancer. Over to you, sir.
Good afternoon, and thank you very much. I would like to start by thanking the research cell for giving me the opportunity to be, if I may say that, inaugural Professor S.R. Nayak Award lecturer this year. Well, for my young friends in the audience and others who may not have known Professor S.R. Nayak and who may not be aware of what this award is, let me inform you. The Professor S.R. Nayak Award is given away by the institute every year in honor of Professor Subhash R. Naik, who was the first head of Department of Gastroenterology at SGPGI. He also held the positions of dean and acting director for some time. He was indeed an eminent scholar, eminent teacher, a researcher, and above all, I feel a great influencer. He has made immense influence, or he has shaped a number of careers, not just of gastroenterologists, but all kind of specialists in this institute, and many things that we do. 2016 to 20, mostly relating as less is indeed more. We do not need to subject patients with breast cancer to extensive treatment to achieve cure. Even with lesser treatment, more convenient treatment, less morbid treatment, we can achieve the same goal in majority. I'm sorry for this interruption, but while the projection comes up again, let me acknowledge the contribution of all my collaborators. This work that I am going to present to you is indeed the work of an entire team, a multi-departmental, multidisciplinary team. And specifically, I would like to acknowledge the contributions made by my senior colleague and my mentor, Professor Sanjay Gambhir from Department of Nuclear Medicine. Primarily, I'll be addressing the issue of sentinel lymph node biopsy, and it was the team of surgeons and physicians or nuclear medicine physicians led by Professor Gambhir in starting 1999, which started this work. So how is breast cancer treated today? Of course, in terms of treatment, surgery remains the mainstay, and breast cancer surgery addresses both the tumor in the primary, that is the breast, as well as the lymph nodal metastasis to axilla. Breast cancers are epithelial cancers, and the first way that they spread is by lymphatics to the axillary nodes. And so we have to address the axilla in some way. Over the years, we have progressively minimalized the treatment or surgery of breast cancer. And indeed today, less is more. And I'll be focusing on how less is more in context of axillary treatment of breast cancer. And in a way, what I would like to focus is how we have been able to evolve a low cost or frugal sentinel lymph node biopsy technique in our institute over the years. And these are the 3 papers or 3 studies which have been published in the recent 5 years, which I'll be focusing on, or which I'll be discussing a little bit on in details. So this is the list of collaborators. And as I said, besides my friends, besides Professor Sanjay Gambhir, I must also mention Professor Sevatkar, unfortunately he's no more, and others in the Department of Nuclear Medicine, the faculty members in departments of pathology and radiation oncology, and in my own departments, including the residents and research scholars. Well, breast cancer is the commonest cancer affecting women globally, as also in our country. And while we continue to treat a lot of women with locally advanced and advanced cancers, but over the recent 2 decades, we now have a fair number of early stage breast cancer patients too. And that has brought us to a kind of a crossroads. While we continue to dabble with all the problems with advanced cancers, simultaneously, we are expected to deliver the world-class treatment for these early stage cancers. And this world-class treatments come at a cost, not just economic cost, but other costs as well. And our country's health system and the patient's resources are not sufficient to meet those costs. And that leads us to a gross mismatch between the ground realities and the aspirations of our society. So that certainly requires a bit of innovation from the medical fraternity to provide high quality contemporary treatment strategies to our patients without the high cost that is involved with these more contemporary and high quality treatments. And not just we need to institute those, we have to provide the scientific community with sufficient data to validate the applicability of these innovative low-cost strategies. And that has been the focus of my research over the last 2 decades. A number of innovations have been introduced by the SGPGI Breast Health Program. Some of these are listed here, but what I'm going to focus is on the low-cost sentinel lymph node biopsy, and specifically the use of low-cost radio tracers and low-cost methylene blue dye and the fluorescein-guided sentinel lymph node biopsy. Well, axillary surgery is an essential component of breast cancer surgery because it gives us the vital staging information, which provides us with the prognosis of the patient, and it helps us defining or deciding the adjuvant treatment the patient would require. It also adds to the loco-regional control of disease, but it comes with some bit of morbidity. So an approach with horses for courses is the right approach here too. And depending on the initial stage at presentation, we decide what kind of treatment strategies are required for that individual patient. And in context of axillary stage, patients who do not have any palpable lymph nodes in the axilla or enlarged lymph nodes identified on preoperative imaging, these are what we call as the N0 patients. And these are the patients who benefit from the strategy of sentinel lymph node biopsy and avoidance of axillary dissection. So sentinel lymph node biopsy is the current gold standard for determining the nodal stage in patients who have clinically N0 axilla. And this is associated with significantly lesser complications or morbidity as compared to the old gold standard that was the standard axillary dissection. It offers excellent local control or regional control without extensive dissection. And in various extensive and very high quality studies, it has been proven that it does not result in any inferior survival when compared to the older axillary dissection. And this is the kind of complete dissection we end up with in patients who have metastatic nodes. And this is this old gold standard axillary dissection is still contemporary in patients who have multiple metastatic nodes. However, this comes with a bit of morbidity, both early and delayed. And more importantly, roughly 2/3 of all patients that we treat actually do not benefit at all from axillary dissection. So the alternative is sentinel lymph node biopsy. And this procedure is based on the orderly axillary the lymphatic drainage system of the breast. The lymphatics from the breast, they drain into various lymph nodes in the axilla. And by detecting those particular few lymph nodes or 1 or 2 lymph nodes, which are at greatest probability of receiving lymphatics from the breast, and so these are the sentinel or sentry nodes of the axilla, and selectively removing them, biopsying them, and seeing if there's indeed any spread of the cancer, we can select patients who are candidates for axillary dissection and avoid axillary dissection in the rest. So this is the kind of strategy we use In patients who have clinically nodes negative axilla, we detect the sentinel node, remove it selectively with minimal dissection, subject it to either rapid frozen section histology or otherwise conventional histology. If indeed there's any metastatic deposit in those sentinel nodes, we go ahead and do a completion axillary dissection. If, however, the sentinel lymph node does not have any metastatic deposits, we can avoid axillary dissection and so give the benefit of avoidance of morbidity. And this is possible, as I said, in more than 2/3 of all patients. For doing the sentinel lymph node biopsy, you have to use certain lymphophilic dyes or tracers which are picked up by the lymphatics and concentrated, they're selectively taken into these sentinel nodes. And there are two different kinds of dyes that we commonly use. One is a color dye, and usually we use blue dyes. Methylene blue is the one which we use commonly. And the other is a radiopharmaceutical. And the radiopharmaceutical helps us detect a hot node, a node which has concentrated the radiopharmaceutical using a handheld gamma probe, the kind that you see in these pictures. And the gamma probe helps us plot the roadmap to the sentinel node. And then we try and locate a blue and hot or a blue or hot lymph node, take it out selectively, subject it to histology, and as I said, we do the rest of the decide rest of the treatment strategies accordingly. For us, this whole journey of sentinel lymph node biopsies started sometime in mid-1999, a few years after the first extensive report of sentinel lymph node biopsy was reported from Italy. Initially, we had to beg and borrow and for both the dyes and the gamma probe and everything. These were not available. Even if we had resources, we could not have bought it in India because these are not marketed in India. And that led us to it compelled us to innovate, to use in-house produced low-cost methylene blue dye and technetium antimony-colloid, which was produced by the nuclear pharmacy of our institute. To give you a comparison of the costs, the commercial dyes at that time, if it was available, it would have costed us, say, $40 per case, the radiopharmaceutical, whereas what we were using was technetium antimony-colloid, which costed less than 100 rupees per case. Similarly, the lymphazurin dye, the standard blue dye that was not available, had it been available, it would have costed $31 per patient. Whereas we used analytical grade methylene blue, which we sterilized after filtration, and the cost was less than 10 rupees. So there was no doubt that we were saving money for the patients and for our system. And in our first validation study, which we conducted between 2000 and 2003, we reported 120 patients with a very healthy sentinel lymph node identification rate and an acceptable false negative rate of 2.1%. And by the way, the gold standard or acceptable false negative rates for sentinel lymph node biopsies globally is less than 10%. So if in hands of any individual surgeon or a team, the false negative rates are in excess of 10%, it means that that team should not practice sentinel lymph node biopsy. Similarly, if we fail to identify sentinel lymph nodes in less than 90% of patients, then we should perhaps not be practicing sentinel lymph node biopsy. From that yardstick, we were good enough to practice this. Much more recently, well, we've been practicing those strategies over years, but often we would face questions about the scientific validity of these practices. And the scientific validity would have come only in the way of a randomized controlled trial of comparing the commercial dyes used versus our in-house produced low-cost dyes. And as one of those studies, which was the research project for MCH of one of my students and was supported by an intramural grant, we compared in a randomized fashion the results of an in-house produced low-cost pharmaceutical versus the commercial radiopharmaceutical. for sentinel lymph node biopsy in early stage breast cancer patients undergoing primary surgery. So this comparison was done between the commercial technetium sulfur colloid, which we bought from Bark. And by the way, Bark products are much cheaper, much less expensive compared to the, say, other radiopharmaceuticals available. And we compared with the results of technetium antimony colloid, which was produced in-house by the Department of Nuclear Medicine. The three key indices that we focused on was the intraoperative sentinel lymph node identification rate, the false negative rate, and the cost incurred in the two arms. And in the prospective randomized way, 78 patients were divided into group 1, which was technetium antimony colloid group, and group 2 of sulfur colloid patients. And methylene blue was used as a standard in either of the arms. Irrespective of the sentinel lymph node histology, we went ahead and did a complete axillary dissection so that we could validate and arrive at the false negative rates. And the comparison of the costs were that in patients who received technetium antimony colloid, the mean cost was less than $1 compared to approximately $13.2 in sulfur colloid group. The results are tabulated here, and you can straight away focus on almost identical sentinel lymph node identification rate and false negative rates. So from this study, we concluded that the accuracy of sentinel lymph node biopsy in early breast cancer patients undergoing primary surgery was comparable when we used either the commercial technetium sulfur colloid or the in-house produced low-cost technetium antimony colloid. So, and then while the in-house produced dye was 15 times more economical. Well, primary surgery is a desirable thing to do, but more and more we are now shifting to post-neoadjuvant chemotherapy surgery, both in locally advanced cancer patients as well as selected early stage cancers, especially in certain biological subtypes like triple negative and HER2 enriched types. Post-neoadjuvant chemotherapy sentinel lymph node biopsy comes with some bit extra concerns. And these concerns emerge out of the fact that systemic treatment induces some bit of fibrosis and perhaps occlusion of the afferent lymphatics of the sentinel nodes, as you can see here in this picture. And so we had to address this issue. And then, by the way, being, practicing in a developing country, we tend to, or we have to treat a larger proportion of locally advanced or stage 3 cancers compared to Western countries. So it is indeed a question that we have to answer. So initial research that we conducted was to validate post-neoadjuvant chemotherapy results in patients undergoing post-NSCT sentinel lymph node biopsy, and this was published in Cancer Research in 2016. But a more systematic comparative study we conducted in between 2016 and 18, where we compared the results of primary sentinel lymph node biopsy, which means before we institute any systemic treatment, we did sentinel lymph node biopsy in a set of patients, and we compared those results with patients who had undergone neoadjuvant chemotherapy. And this was a study exclusive to stage 3 cancers. And the reason I am emphasizing this is because this is the kind of patients that we have to cater to large in a large proportion. And these are the kind of studies we do not expect to come from Western countries. So in a non-randomized prospective study, we had 50 patients who underwent primary sentinel lymph node biopsy, and the rest 70 underwent post-NSCT sentinel lymph node biopsy. And we compared the sentinel lymph node identification and the false negative rates between the two groups. Comparing the two groups, the sentinel lymph node identification rate was awfully short of the expectation of 90% in patients who had undergone neoadjuvant chemotherapy. So this was certainly not acceptable. But patients who had undergone primary sentinel lymph node biopsy, the sentinel lymph node identification was good enough at 94%. Looking at the subgroups, such patients who had stage 3A disease, which means they had T3 and N0 or at worst N1 stage to begin with, the sentinel lymph node identification rate was quite good, even when the surgery was post-NSCT. However, in patients who had T4B, which is a stage when the patient has skin involvement because of breast cancer, or N2A stage, which is when there are matted nodes in the axilla, these are the kind of patients where we found, irrespective whether the surgery is primary or post-NSCT, the identification rates are dismal. Similarly, the false negative rates in patients who underwent post-neoadjuvant chemotherapy sentinel lymph node biopsy, they were unacceptably high at 13.5%. And yet again, we found in patients with stage 3A disease, perhaps it is okay to do sentinel lymph node biopsy, either primary or post-NSCT, but it is certainly not acceptable for patients who have stage 3B disease. So we concluded from this study that sentinel lymph node identification rate is unacceptably low, and the false negative rates are unacceptably high in patients who have T4B or N2A disease. And this has led to quite a bit of acceptance of this strategy. And globally now we see a number of publications quoting these studies, these results, and also making similar inferences. And finally, I would in very short describe this another, I would say, path-breaking kind of study. So far, the two studies that I discussed involved use of radiopharmaceutical and a gamma probe. And I don't need to tell you that how few centers in our country and perhaps across the world would have the luxury of having a nuclear medicine facility. And the cost of gamma probe continues to be considerable. So if there could be a strategy of doing sentinel lymph node biopsy without use of gamma probe and radiopharmaceutical at all, it would be very helpful. It would help wider usage of this strategy. And this study that we conducted was primarily aimed at that. This was again the MCS project of one of my students, and it was supported by an ICMR grant to her. And here, instead of using, in this study, we compared the sentinel lymph node identification rates and false negative rates using fluorescein, which is a low-cost fluorescent dye, and a very low-cost blue LED light. Of course, there's another fluorescent dye available, which is ICG. Unfortunately, for using that, one needs to use a very expensive near-infrared detection system, a CCD device, which is multi-crores or at least close to a crore, whereas what we used was a much cheaper fluorescein dye. The study was presented by the student in World Congress of Surgery and was awarded the best poster. I'm sorry for this bit of jumbled up slide, but this was a prospective cross-sectional non-randomized validation study in 65 patients as per the sample size calculation. And we compared the sentinel lymph node identification rates and the false negative rates using the low-cost fluorescein coupled with blue LED light. The fluorescein cost ₹90, and the blue LED light that we bought was for 250 rupees and can be used multiple times. Compared that with radiocolloid and handheld gamma probe, either alone or in combination with methylene blue, and we found that the sentinel lymph node identification rate and the false negative rates were very comparable between use of fluorescein and radiopharmaceutical. And as a result, we could conclude that sentinel lymph node identification, use of fluorescein, low-cost fluorescein, is as good as radiocolloid. Perhaps fluorescein can now replace radiopharmaceutical for sentinel lymph node biopsies, thus making sentinel lymph node biopsies acceptable or available widely. So in summary, what I have talked about is how less is more in context of axillary surgery of breast cancer, and what has been the impact of these low-cost innovations and practices at SGPGI. We now have a routine application of sentinel lymph node biopsy in early breast cancer patient and selected large operable and locally advanced breast cancer patients undergoing primary or post-neoadjuvant chemotherapy surgery. We are able to do a single stage complete treatment for majority of our patients without adding any substantial cost to their treatment. And this has also helped us train quite a few numbers of surgeons, nuclear medicine teams, and this has led to a wider applicability or acceptability. And I can't help but remember when we started talking about sentinel lymph node biopsies in 2000, 2001, I used to be shot down or in various conferences and workshops when I demonstrated these in, say, like a conference of Indian Association of Surgical Oncology, and almost the entire house would say, "Oh, this is not for India." And today, almost every center worth its salt in the country is doing sentinel lymph node biopsy. So it's entirely because of this team of very active collaborators, very able collaborators, that we have been able to establish the utility of sentinel lymph node biopsy. And I once again thank the research cell for this opportunity. If there are any questions, I'll be very happy to take them.
Thank you, sir, for your insightful lecture. Along with S.R. Nayak Award, we have also introduced an oration of S.S. Agarwal Award, and for this year, our colleague Sangam Rajak has been honored with this award. So I would invite Sangam to present his keynote lecture. We'll be speaking on loss of ULK1 attenuates cholesterogenic gene expression in mammalian hepatic cells.
A very good afternoon to everyone, and my special thanks to Director SGPGI and the Research Organizing Committee for giving me an opportunity to present my work. The title of my talk is Loss of ULK1 Attenuates Cholesterogenic Gene Expression in Mammalian Hepatic Cells. So the first question is, what is ULK1? ULK1 is an autophagy protein which initiates the autophagy signaling in response to energy and nutrient deprived condition. And being a kinase, it phosphorylates several other autophagy proteins like ATG13 and Backlin-1 that initiates the cellular autophagy. And due to its kinase activity and druggability, the new ULK1 inhibitor has been recently developed. So this slide gives you a small description of what the autophagy is and how ULK1 regulates the autophagy signaling. So basically the autophagy is the self-digesting mechanism basically responsible for the removal of like damaged organelles, malformed protein which is formed during the biosynthesis, and viruses, bacteria, and other non-functional proteins. And all these components which is going to be degraded are engulfed by the structure known as the autophagosomes, and these autophagosomes further fuse with the lysosomes which contain the hydrolytic enzyme and degrades the cargoes. So in simply, the autophagy signaling is a cascade of reaction which includes the nucleation, initiation, expansion, autophagosome formation, and its maturation, degradation, and so on. And here the role of ULK1 is to initiate the autophagy signaling, wherein it also involved in the formation of autophagosome. So this is the canonical role of ULK1 in autophagy signaling. So besides the canonical role of ULK1, there are non-canonical signaling has been recently discovered, which includes the interferon signaling, ER to Golgi protein trafficking system, and immune responses. So what was the research question and why this kind of studies are required? Since our lab has special interest into understanding the role of autophagy and autophagy related protein involved in the various metabolic diseases, especially we are looking in liver function. So here we wanted to investigate the role of Evelk1 in hepatic metabolism. So in this regard, we asked whether this Evelk1 play role in hepatic metabolism by a canonical role or a non-canonical dependent. So to answer this, we silenced Evelk1 gene in C57BL6 mice and mouse hepatic cell line, that is AML12. And then we perform the unbiased transcriptomics approach, such as RNA-seq and microarray, and followed by the pathway analysis. And then we this result was further validated by the gene expression analysis. And we further we wanted to see whether this effect was conserved across the species or not. So we used the human hepatic cell line, that is HepG2 cells, and then we silenced Evelk1 gene by siRNA. And then we performed the RNA-seq followed by the pathway analysis, and then we performed gene expression analysis to validate the result. And then we also investigate the molecular mechanism behind the regulation of this signaling. So coming to the result. So I would like to draw your attention to these slides, which shows the loss of Evelk1 inhibits the expression of cholesterogenic gene in mouse AML12 cells. So here we have used AML12 cell line and knocked down by the Evelk1 siRNA and confirmed by the immunoblot shown in the figure A. And after the confirming the knockdown efficiency, we performed the microarray analysis followed by the pathway analysis. And interestingly, we have found the cholesterol biosynthesis pathway was down. And then in figure number 1, we can show here, these are the key regulatory enzymes which is involved in the different stages of cholesterol biosynthesis pathway. And to validate our microarray data, we performed the genetic analysis, and we have found all these genes are down upon the Evelk1 silencing. And furthermore, we estimate the intracellular cholesterol level by using the Philippine stain. And interestingly, here we can see upon the Evelk1 silence group, the cholesterol level was down in the knockdown cells. So this result suggests that the genetic silencing of Evelk1 inhibits the expression of cholesterogenic gene in mouse AML12 cells. Next, to validate our in vitro results in vivo, here we have used C57BL6 mice and genetically silenced by the Evelk1 gene by tailwind injection, and confirmed by the immunoblot shown in the figure A. Then we again perform the microarray analysis followed by the pathway analysis, and the same result we obtain here as we obtain in our vitro result. The cholesterol biosynthesis was down here. And then this further gene was further validated by the genetic expression, and all this regulatory gene was down upon the Evelk1 silencing. And also we also measured the intrahepatic cholesterol level in knockdown mice. And after the knockdown, the cholesterol level was down upon the Evelk1 silencing. So this result suggests that the genetic inhibition of Evelk1 inhibits the expression of cholesterogenic gene in mouse liver. Next, we further wanted to see whether this effect was either autophagy dependent or autophagy independent. So here we have used two important component of autophagy, that is Backlin-1 and ATZ5, and a silence in the AML12 cells. And after confirming the knockdown efficiency as shown in the figure A, then we perform the genetic expression of cholesterol biosynthesis pathway. And interestingly, here we can see neither ATG5 nor Backlin-1 has any suppressive effect on cholesterol genes. So possibly this is autophagy independent regulation. To further validate this result in human model, here we use the human hepatic cell line, that is HepG2 cells, and further knocked down by the siRNA and validated by the Western blot as shown in the figure A. And after that, we perform the RNA-seq followed by the pathway analysis. And in panel B, we can see here the cholesterol biosynthesis pathway as well as the SREBP signaling. Both are down upon the EVLK1 silencing. And then this result was further validated by the gene expression analysis, and all these key regulatory genes was down upon the EVLK1 silencing. So this result suggests that the EVLK1 loss suppresses the expression of human cholesterogenic gene. We investigated the molecular mechanism of EVLK1 in cholesterol biosynthesis. So as we know that the SREBP2 is the master transcriptional regulator in cholesterol biosynthesis pathway in hepatic cells. And we wanted to investigate its regulation by the EVLK1. So here in figure A, we can see there is a complex known as the SRE, is the sterol regulating element, and which provides the pocket for the SREBP2 binding. Once this SREBP2 bind to this SRE complex, the transcription turns on, as you can see in the figure A. And other than that, the AKT, the anabolic regulation of the AKT has been already shown to upregulate the SREBP2 level in mammalian hepatic cells. And furthermore, the AKT regulation of the SREBP2 is mediated by the induced inhibitory phosphorylation and inhibitory phosphorylation and nuclear exclusion of FOXO3. Here we can see in the figure B, and this FOXO3 is the nuclear repressor of SREBP2. So therefore, we wanted to investigate whether this AKT FOXO3 signaling was perturbed in case of EVLK1 silence cells or not. So here we silenced EVLK1 gene in mammalian hepatic cells, and then we found phospho-AKT and its substrate, that is phospho-FOXO3, was down. So possibly this result shows that it is mediated through the SREBP repression in the cholesterol metabolism. And then we further wanted to investigate whether the role of FOXO3. So here we perform another rescue experiment in which we co-silence both EVLK1 and FOXO3. And interestingly, we can see in figure E, after the silencing of FOXO3 rescues the repression of SREBP2 and its downstream, that is HMG-CR. And further, this work we also performed with the EVLK1 inhibitor, and the same result we obtained here. The phospho-AKT, SREBP2 and HMG-CR, all three key regulatory protein was down upon the EVLK1 silencing. So these results suggest that the EVLK1 inhibits the expression of cholesterogenic gene in human hepatic cells via the AKT FOXO3 pathway. So this is the graphical summary which shows the loss of EVLK1 reduces the phospho-AKT level, and it mediates the FOXO3. It further represses the SREBP2 repression and finally reduces the cholesterol regulatory genes. So this study was published in last year in Frontiers in Cell and Developmental Biology. So coming to the conclusion, this study utilizing the unbiased transcriptomics approach uncovers the novel function of EVLK1 in regulating mammalian cholesterol biosynthesis. And deranged cholesterol metabolism has been reported in the several diseases. Therefore, therapeutic inhibition of EVLK may prove to be an important treatment strategy in humans. So at last but not least, I would like to thank our institute SGPGI for the infrastructure support and our lab funding, DVT Welcome India Alliance, and our collaborators, University of Padova, Italy, and Duke Medical NUS, Singapore. Thank you.
Sir, in this mice model, have you checked the cholesterol level in serum?
Yes, we have measured the cholesterol level, but trend was there, but it was not very significant. But this could be due to following reasons like less number of animals and siRNA based knockdown was transient. So chronic exposure or long-term exposure can be useful for the treatment for the lower cholesterol level can be obtained for this.
Excuse me. So it's very nice presentation, and I just wanted to know that whatever mouse you use, mouse model, so you use the genetic engineered mouse or you genografted those altered cell line inside that?
This is not genograph. This is C57 BL6 mice which you genetically knocked down by the siRNA base. So this is not a genetically silenced.
And what method you use for that, like either that viral system or
No. This is siRNA based hydrodynamic tailwind.
So that is stable or just like transient transfection?
This is transient because it's a siRNA based, so it is transient.
Okay. And one more question regarding that silencing of ULK1 gene. So that how it is regulating to the next gene, downstream gene you conform. Did you perform any direct regulation or any like indirect regulation?
In case of autophagy, we have already mentioned in earlier slides because there is no correlation with the this autophagy dependent manner. So we can say that this is autophagy independent, and other than that, we haven't checked any other regulations as you were saying.
Because the final conclusion, whatever was made, so it should be like either promoter assay, like reporter assay or something, so that we can finally conclude that this gene regulate another downstream one.
No, we haven't.
Thank you, Sangam, for that wonderful lecture. With this, we have come to the end of our keynote lecture session, and I now invite Dr. C.P. Chaturvedi for a vote of thanks.
So good afternoon, everyone. So it's give me an immense pleasure to extend a vote of thanks to everyone who have played an important role to make this event successful. So I extend my heartful gratitude to Director SGPGI, Professor R.K. Dhiman sir, for his guidance, support and vision. Dean Professor Anish Srivastav sir, thank you sir for your valuable contribution. Faculty in Charge Research, Professor U.C. Ghoshal has been instrumental in the entire process, leading from the front and giving a shape to the idea of hosting the research day. Thank you, sir. I would like to thank other team member of Research Day Committee, Mrs. Prabha, Dr. Rohit, Dr. Alok, Professor Anita Saxena, ma'am. Contribution for logistical support has been immense. Thank you, ma'am. The judges who have took the time out and came here to evaluate the posters belongs to various institutes like CDRE, RML, KGMC, definitely deserve a big thanks. Nothing is success if you don't have participation. So it's like thanks to all faculty members, residents and the PhD students who have come up with a great number and make this event very successful. And also our speakers are the speakers for the event also. They deserve a big thanks. Professor Das, Professor Mukhopadhyay, Professor Agarwal and Sangam, thank you very much. Mr. Vijay and the telemedicine team for audiovisual facility, auditorium staff for managing the auditorium, print media and the electronic media for giving us the space. Thank you. And last but not the least, special thanks to each and every person who contributed directly or indirectly supported this event. So thank you all and have a great day.
I now request everyone to kindly make your way to the hall to the left for lunch. And I request Honorable Director, Dean, Faculty in Charge Research, and our research cell staff for a group photograph. Thank you all.